Hello, my name is Jacob Powell, and I'm from the University of Alabama in Birmingham. This is my research entitled Emergency Department-Based Food Insecurity Interventions, a Systematic Review and Narrative Synthesis. So the authors of this paper have no disclosures to make known, no conflicts of interest. What is food insecurity? So it's a social determinant of health that describes the lack of access to consistent and nutritious desirable food. We took an interest in this particularly from the perspective of social emergency medicine, trying to approach social determinants of health, the entire patient, understanding them via a biopsychosocial model rather than biophysical. Food insecurity starts at the moderate food insecurity of compromising quality and variety of food, so not just the lack of food in general, but it does progress to severe food insecurity with experiencing hunger multiple days in the week. Social emergency medicine, food insecurity affects 37 million people in the United States, and the ED sees many food insecure patients annually. So objectives were to systematically review literature for studies that implemented interventions targeting food insecurity. We found multiple abstracts and manuscripts, 491. However, after inclusion and exclusion criteria were used, we found two worth qualitative analysis. So the conclusion is that obviously there aren't very many pieces of literature here. However, as we'll see, these pieces of literature seem to suggest the appropriateness of the emergency department for identifying food insecure patients and also addressing this issue. Starting with, this is our inclusion and exclusion criteria. Starting with Complete Eats by Cohen et al. This study described the intervention adopted by Children's Hospital of Philadelphia in 2017. CHOP was designated as a summer food service program, which is a federal USDA program designed to provide food for children on free and reduced lunches during the summer months when schools are closed. Patients were given boxed meals and informed about other already existing SFSP sites. However, the intervention was later adopted by multiple hospital departments at CHOP and as a perennial summer program. So CHOP essentially became an SFSP site permanently in itself. The advantage of this were direct material provision of food to patients. It was successful and easy to implement based on the surveys that they did at the site, both for providers and patients. And then it was informative for the parents of the patient population who often reported not knowing that this program existed in their community. So it was time limited, only available during the summers, and then only accessible to the pediatric population mentioned before on free and reduced lunches. So EMR orders for referral, Martel et al. Was our next study, and this was a provider education program that was informing providers of an already existing EMR referral order. So the order was for referral to a food bank network called Second Harvest Food Bank. That's a nationwide food bank network. The study did not disclose the actual location, however, described this as an urban hospital setting. A two-question screening tool was used and to identify patients who were food insecure, and the education program was later expanded to residency programs and hospital services due to its success. So patients were easily identified by the two-question screening tool, and they were put in touch with a robust social safety network. Second Harvest had the expertise needed to connect patients with the resources they needed for consistent access to better food, and this had a very low burden overall on the healthcare resources and workers who were working in the emergency department, as all they had to do was just screen patients and then enter a referral order. So it was reliant on the patient information, which obviously is not always available in the emergency department setting. And then implementation did require separate educational sessions, which kind of is a benefit in pushing providers more towards a biopsychosocial understanding. However, of course, is a drain on time and resources. So it is provider dependent. Providers had to remember to use the service, or to use the order rather, and then it was location dependent, as this might not always work in a place with a more rural area or a less robust food bank network. So a few excellent studies that involved food insecurity centered interventions. The two that we described had very different methods. However, they each seemed to have promising results. They illustrated the appropriateness of the emergency department as a setting for identifying food insecure patients. And why would we care? Because food agricultural yields are projected to decrease in the coming decades due to climate change. So I live here in the southeast in this orange region that you can see. And so overall agricultural yields are projected to decrease. That means that food insecurity may be a growing problem in our lifetimes, not just worldwide, but also here in our own backyard. So as we can see, food insecurity rates are decreasing. They do affect minority patients at a greater rate than white patients. And food insecurity is projected to be this growing issue worldwide. It might also be a growing issue in the United States. We're not sure. So in keeping with the mission of social emergency medicine, we believe that the emergency department can provide meaningful changes through these minor interventions adopted in the emergency department setting. And this would address overall population health and be a great benefit for our communities. So questions for you are, should further interventions be tested? Can interventions and other social determinants of health coincide with these interventions in food insecurity? And then how much of this responsibility is up to the physicians? So according to one, Rudolf Virchow, he said that the physicians are the natural attorneys of the poor and the social problems should largely be solved by them. So he was very prominent in the emergence of medicine as a social and humanitarian science, and we see the study of social emergency medicine as continuing in the same line of thought as Virchow and other humanitarian interventionists. Thank you for your time. I'm Jay Cowell, and it has been a pleasure.
Hello everyone, my name is Nicole McCamus and I'm a fourth-year medical student at Frank H. Netter, MD, School of Medicine. Today I'll be discussing my project titled Assessing Healthcare Provider Knowledge of Human Trafficking. Here is the poster in its entirety, and I will be going into detail shortly. It is important to note that an average of 28 to 50% of victims come into contact with the healthcare system at least once during captivity. This places healthcare providers in a prime position to help in the fight against modern-day slavery by screening, identifying, intervening, and making a plan of action to help victims. Since there was no established survey examining knowledge of human trafficking among healthcare providers, we were tasked with creating one. The survey asked a range of questions, including demographic information, previous training, and knowledge levels. Table 1 shows the knowledge items assessed in the survey. Responses to the survey were recorded using Qualtrics. Participants included EMTs, fellows, medical assistants, medical students, nurses, nurse practitioners, nursing students, paramedics, physicians, physician assistants, physician assistant students, residents, and social workers. Table 2 shows a breakdown of demographic information recorded. Table 3 discusses how only 42.2% of participants previously received training, while 93.4% felt they would benefit from training. It is important to note in Figure 1 that the mean knowledge score of the entire sample was only 2.64, below the average of 3. Figures 2, 3, and 4 show how knowledge scores varied by age, region, and level of training. Participants in the age group from 61 to 70 were found to have the highest level of knowledge when compared to age groups above and below those numbers. Knowledge was highest in the Midwest, with the South, West, and Northeast following closely behind. Amongst all of the training levels, social workers were noted to have the highest knowledge levels, followed closely by nurse practitioners. Approximately 14.4% of respondents felt the need to add in additional commentary to the survey. They not only discussed survey design, but also the need for an ideal training program while requesting further training. In conclusion, the over 6,600 participants felt they would benefit from human trafficking training. This further indicates the need and potential benefit for human trafficking training across all levels in the healthcare field. Thank you.
Good morning, everyone. My name is Melissa Ponder, and I'm a third-year emergency medicine resident at Christus Health Texas A&M Emergency Medicine Residency Program in Corpus Christi, Texas. My research is titled Racial Disparity Research Articles Were Uncommon in Long-Standing Emergency Medicine Journals for 2009 and 2019. Thank you to my co-authors. I have no disclosures. To begin, the emergency department is known as a social and healthcare safety net for those marginalized in society. Research has shown that minorities disproportionately use the emergency department for their healthcare. For these reasons, it is even more important for us working in the emergency department to have heightened awareness of racial biases and to improve our own cultural competence. It is well documented that racial and ethnic inequities exist in the delivery of healthcare in the United States. This has been attributed to many different factors, including poverty, insurance coverage, access to care, and even physician bias, while other studies have shown that these disparities still exist after adjusting for socioeconomic factors. Because of this, addressing racial disparities in healthcare has become a hot topic and is particularly important in emergency medicine. Many federal initiatives and academic society consensus reports have been put forth within the last 2 decades to address these racial disparities. So I wondered, how did we end up? What have we done, or how much more have we studied since then? Our objective was to determine if research publications that focus on racial disparities would increase within the long-standing U.S. emergency medicine journals from 2009 to 2019. In terms of methods, this study was carried out at an urban community-based residency program. The study was a structured retrospective review of research publications for both 2009 and then 2019. We reviewed 4 top, well-respected, and long-standing journals in our field, which included Academic Emergency Medicine, American Journal of Emergency Medicine, Annals of Emergency Medicine, and Journal of Emergency Medicine. Once racial disparity articles were identified, we then grouped them into 5 different categories depending upon the topics discussed in the articles. These categories included access to care, evaluation and testing, treatment, outcomes and quality of care, and medical education or professional representation. Any article could be placed into more than one category. A second blinded study author reviewed a random sample of 30 articles to assess for inter-rater reliability, or CAPA. The author reviewed the title and abstract to evaluate first if the article related to racial disparity, and then placed all articles into one or more of the 5 categories that we just described. We had a PhD statistician run and analyze all of our data, where categorical data are presented as frequency of occurrence and analyzed using 2 sample test proportions. For our results, we evaluated a total of 3,775 articles, with 1,504 being from 2009 and 2,271 from 2019. We identified 4 total articles addressing racial disparity from the entire year of 2009 and just 12 articles from 2019. We also categorized each of the articles to see how the racial disparity subtopics differed in 2009 versus 2019. Out of the 4 articles in 2009, none addressed access to care, treatment, or medical education and employment, whereas half discussed evaluation and workup, and half addressed outcomes and quality of care. Compare this to 2019, where 1/3 pertain to access to care and outcomes of quality of care, 25% to treatment, 16.7% to evaluation and workup, and just over 8% to medical education and employment. Furthermore, we found no statistical difference in the proportion of total articles addressing racial disparity for each year. We also found no statistical difference in the proportion of articles addressing racial disparity within each of the 4 individual journals for the 2 years. Our inter-rater agreement was either perfect or near perfect for determining whether or not an article was related to racial disparity in all disparity subtopics. Now for our discussion, while we observed a paucity of research regarding racial disparities within the emergency medicine literature, review of the medical literature at large has shown an impressive amount of evidence that racial disparities exist in many facets of healthcare, including medical treatment, imaging and workup, or undergoing medical procedures. Disparities are also seen in outcomes and quality of care, medical education and employment, and also manifested in healthcare provider bias. As I briefly mentioned earlier, there have been multiple federally backed programs created to improve racial disparities in healthcare. For example, every 10 years, the CDC's Healthy People Initiative identifies problems and implements plans while monitoring progress through time with the hope of reducing health disparities. Additional steps have been taken, such as with the HHS Action Plan and the Health Equity and Accountability Act passed by Congress as well. Medical societies have also published consensus reports on racial disparities, including the Institute of Medicine and the Society of Academic Emergency Medicine, which made recommendations on how to move forward with identifying and correcting racial inequities, particularly through research. So we put all these things in place, yet it seems we may not be fully addressing the issues, even when leaders in our own field have made recommendations how to do so. While our study has suggested that there is a gap in racial disparity emergency medicine research, particularly within the last decade, there were some limitations to our study. We limited our literature review to only 4 U.S. emergency medicine journals and had a small sample size. We also did not account for the years between 2009 and 2019. We simply compared the 2 years, which could have led to a sampling bias. In conclusion, within the 4 journals we reviewed, research directed towards racial disparity in emergency medicine was infrequent and did not significantly change between 2009 and 2019. Investigators within emergency medicine should address persistent gaps within the literature regarding racial disparities so that we may ensure equity of care for all of our patients. Thank you for your attention, and I'll be happy to...
Okay, hello everybody. So my name is Cortland Brown, and I'm Vice Director for Diversity, Equity, and Inclusion at Carolinas Medical Center Emergency Department. My talk is on the experiences of underrepresented medical students and physicians in the ED, from implicit bias to microaggressions. First, I have no disclosures. And next, I want to give a little bit of a background to set the stage. So, increased diversity among medical providers contributes to higher satisfaction and outcome for patients. Despite this, only approximately 10% of EM physicians identify as an underrepresented ethnic minority. In addition, it's known that receiving care from a female provider is associated with decreased hospital mortality and readmission rates, improved diabetes management, and increased referral to specialists. Despite 50% of med school classes identifying as female, only 25% of EM providers identify as such. And lastly, there are known gender and racial disparities in regards to promotion and rank. So what are some categories for discrimination that physicians face? Microaggressions are one. Microaggressions are brief daily exchanges that send denigrating messages to a target group. They're often based on implicit bias, which is the tendency to automatically associate people with a stereotypical characteristic of the identity group to which they belong. So studies have connected physicians' implicit bias with inequitable patient treatment. Black patients, for example, are less likely to receive EKGs, chest x-rays, and PCI for suspected ACS. But what about emergency medicine? So few studies have examined the effect of implicit bias and microaggressions among EM physicians. One study, a 2017 meta-analysis, found only one study that focused on EM physicians, and they saw that there was no association between implicit bias and treatment recommendations for pediatric pain and asthma management. To our knowledge, there's no studies that examine the counter relationship, the patient as well as colleagues' implicit bias and microaggression against EM providers. We aim to address this gap in the literature. So no previous questionnaire existed that addressed the study question. So we designed our own and then had a survey methodologist review it, and we piloted it through our intended audience. Our final survey was distributed to medical students rotating in the emergency department, residents, fellows, and attendings across the country. We analyzed potential relationships between self-reported experience or witness of microaggressions and implicit bias with available respondent demographic variables using logistic regression. Variables that displayed some level of association with the primary endpoint were further explored with multivariate regression to estimate odds ratio and 95% confidence intervals. Exploratory analyses of the experience of specific types of microaggressions were also assessed with proportions odds logistic regression models to describe where these outcomes were associated with any of the demographic characteristics. So we had 277 completed responses, and you can see the breakdown of the various categories here. And we found that experience with microaggressions was common. 65% of respondents reported personally experiencing it, and 85% said that they witnessed a microaggression in the emergency department. Respondents who identified as cisgender female or non-white were much more likely to report experiencing any microaggression. We also asked individuals to report how often they experienced the following scenarios. You can see on the x-axis is the proportion of individuals that reported experiencing the scenario on the y-axis, never, ever, monthly, and weekly. And you can see that misidentification, being mistaken for someone else in or not being identified as a clinician, was the most common form of microaggression. 54% of respondents reported being mistaken for another person at least once a month, and this was much more likely to be reported with trainees compared to attendings and non-white compared to white physicians. Furthermore, 62% of respondents said that they were mistaken for non-clinician ED staff at least once a month, and this was strongly associated with gender. 52% of females said that they had been mistaken for other non-clinician ED staff almost daily, and only 3.5% said that they've never experienced this. For male respondents, however, only 1% said that this was an almost daily occurrence, while 43% said that they never experienced it. Misidentification as somebody who shares an aspect of somebody's identity, such as speaking the same language as a primary language, was also common. And 79% of total respondents reported experiencing this. Approximately 54% and 27% respondents said they experienced this at least once a month and at least weekly, respectively. Overt discrimination from patients towards staff were also common occurrences. 76% of respondents said that they had been called a vulgar term based on their identity characteristics by a patient, and 11% and 26% of the total respondents said that this was a weekly and monthly occurrence, respectively. And 21% of individuals said that they had been called a vulgar term based on their identity characteristics by another staff member. And this is one of the saddest slides that I think. So 35% of individuals reported that they felt the need to conceal a certain aspect of their identity in order to be treated fairly. 16% of individuals said that this was at least once a month, and 10% said that they experienced this at least weekly. So what were the limitations? There were a few. So our study was limited by the self-selection of the respondents. Those who completed the survey may have had some introduction to the concepts and could have potentially been more aware of these issues. In addition, to obtain the greatest number of responses and therefore the greatest representation of the country, we elected to distribute our survey via multiple methods, including listservs. Subsequently, we weren't able to calculate a true response rate. We ensured, however, that we had respondents from every region of the country and both academic and community sites. So, in conclusion, the frequency of overt discrimination, microaggressions, and implicit bias experienced by EM providers had not been previously reported. We found that microaggressions and implicit bias were common experiences in the emergency department. Furthermore, we found that women and non-white individuals experiencing them at a higher rate than their white male counterparts, and that the most common form of microaggression for both women and non-whites was misidentification. Lastly, our data suggests that many subtle and overt microaggressions or overt discrimination were collectively experienced by providers of all training levels. This highlights the concept of intersectionality, which denotes the overlapping social identities of each individual. These interconnected social identities often carry different privileges in specific environments. Here are our references, and thank you so much for listening to this talk, and I would gladly answer any questions. Thank you so much.
Hi, my name is Miranda Brown, and I'm a medical student at the Medical College of Wisconsin in Milwaukee, Wisconsin. I will be discussing factors influencing show rates of emergency department referrals to primary care safety net clinics. The authors of this presentation have no financial conflicts of interest to disclose. On average, 37% of all emergency department visits are non-urgent, defined as conditions for which a delay of several hours would not increase the likelihood of an adverse outcome. Using the emergency department instead of ambulatory care facilities causes excessive healthcare spending, unnecessary or duplicative testing, and a missed opportunity to form a longitudinal relationship with a primary care provider. The Emergency Department Care Coordination Program is a community-wide initiative established in 2007 by the Milwaukee Healthcare Partnership. It's composed of 8 adult emergency departments and over 25 safety net clinics throughout Milwaukee, Wisconsin. This program allows providers from EDs to refer patients seeking care for non-urgent or avoidable health conditions to primary care follow-up appointments for further management. The target patient population includes Medicaid and uninsured patients, individuals with chronic conditions such as asthma, COPD, diabetes, and hypertension, pregnant women, and patients not connected with a primary care health home. In 2018 to 2019, over 5,000 appointments were scheduled through the EDCC program, with a 43% show rate to follow-up appointments, leaving some room for improvement. The aim of this project was to identify factors that may influence patients' abilities or desire to attend scheduled follow-up appointments. Using this information, we will develop targeted program interventions to increase show rates to follow-up appointments. By doing this, we hope to improve the connections between Medicaid and uninsured patients with primary care homes in Milwaukee and decrease avoidable ED visits and associated hospitalizations. The study utilized the cloud-based scheduling tool used to make EDCC appointments and referral information to assess factors contributing to patient show rates. All referring emergency departments were included, and only federally qualified health centers were included amongst the receiving clinics. The data set was analyzed with binary logistic regressions and included the following data elements listed on this slide. There is a significant difference in show rates amongst different age groups, with patients aged 65 and older having an increased likelihood of attending. When looking at show rates based on the number of days elapsed between ED visit to follow-up clinic appointment date, there was a significant difference with patients being seen within 5 days of their emergency department visit having an increased likelihood of attending. There's a significant difference in show rates based on insurance type, with the uninsured more likely to attend follow-up appointments than other insurance types, particularly Medicare insurance holders. We also found that there was a significant difference in show rates amongst various federally qualified health centers, with patients seen at Clinic A who are more likely to attend than patients seen at Clinic D or E. Patient sex, referring ED, and provider type did not have a statistically significant difference. Looking at these results, more efforts are needed to motivate younger individuals to attend their follow-up appointments. Older individuals could be more likely to follow up because they typically have more comorbid health conditions to manage, or there may be more of an emphasis on managing these chronic conditions. Conversely, younger individuals could perceive their health as stable, causing them to feel less motivated to attend follow-up appointments. It is also important to schedule follow-up appointments within 5 days of their emergency department visit. More timely appointments may have been more likely to be at the forefront of patients' minds. It's also imperative that receiving safety net clinics have an appointment system that provides ample appointment slots within a few days' notice. A model that books appointments into a safety net clinic's walk-in or urgent care center may allow for more appointment flexibility, as some participating FQHCs currently do. Another option is to double book visits into the same appointment slot, which would allow for more available appointments and mitigate the effects of no-shows, although this can create workflow issues if both patients arrive. Differences in show rates amongst the individual FQHCs could be due to multiple factors, including differences in resources, cultural competency, appointment times and availability, and clinic location. Further analysis needs to be performed to determine why there are differences in show rates between individual FQHCs. The next steps of this project will be to develop clinic-specific analyses of the larger data set. We will then meet with individual FQHC leadership to discuss the barriers individual clinics face and what strategies they have utilized to successfully integrate EDCC appointments into their workflows. Additionally, meetings will be conducted with ED staff regarding which patients are good candidates for EDCC referrals and what populations may need additional interventions. These lessons learned will be disseminated to other receiving clinics and EDs in order to improve show rates to these follow-up appointments and ultimately reduce non-urgent utilization of community EDs. We would like to thank the organizations participating in the EDCC program, including the EDs at Ascension, Advocate Aurora and Freighter, and the FQHCs. Thank you.
Hi, my name is Ben Fenard, and I'm a second-year medical student at Thomas Jefferson University. I'm really excited today to be presenting about opioid use disorder patients and their experience in the emergency department. And I couldn't have done any of this without my team. Their names are listed below. I have no financial COIs to disclose. In thinking about opioid use disorder patients, it's important to think about stigma because this population is stigmatized more than any other population, including above mental illness or intellectual disability. We know that stigma impacts care, and we know anecdotally that patients who feel that they encounter somebody who's particularly compassionate towards them are more likely to go to rehab. And then on the reverse, if they encounter somebody who's not compassionate towards them, they might be more likely to RMA or leave or not come back to the ED if they need to, and be disenfranchised with the healthcare system as a whole. So our research looks at, from a patient perspective, how are these patients going through the ED? What are they encountering when they do that? So we first started by surveying our staff and their attitudes towards this population, and then used that to send virtual patients through an environment where we could record what's happening. And I'll get into a little bit more of the details in the method section. So here's the survey we used. It's a validated tool that's previously been used to give us a quantitative result for qualitative statements. And so these are the statements that are asked, and we gave this to our clinical and non-clinical staff in the ED, anybody from a security guard to a physician to a nurse, anybody in between. And we grouped that by job. So for data geeks like me, it's really great. We get a number, and that is kind of a proxy for how much bias you have. And so we grouped that by, security guards have this. Here's the list for nurses. Here's the list for patient access. And then we created a virtual environment using that. So here's the virtual environment. The flow chart, the patient moves from security guard to patient access to nurse to ED tech all the way through here. And there's a few kind of if statements that we coded in. And this was all coded in Python. And what the code does is it starts with the virtual patient, and they have their first interaction. And their first interactions with the security guard, the code goes to the list of security guards and their MCRS scores as proxy for bias, and it pulls it and tags it onto that patient and says, okay, well, you had this interaction with this specific security guard. And then they hold that number as they move on to second interaction. And that second interaction is with patient access. So they go to patient access and pull a random number from our list and tags it there. And it continues like that for the rest of the patient flow. And that is one patient. And so we did that process for 100,000 patients. And then we looked back and said, what is the probability that they're encountering somebody who is particularly compassionate towards their condition? And what's the probability that they're encountering somebody who's perhaps not as compassionate towards their condition? This interaction 7, a physician, resident, or nurse practitioner, that was informed by EPIC data going back 1 year. So 93% completion rate for our survey. We felt good about that. That's high. No significant difference in mean among the healthcare worker job types. So security guards had the same MCRS score as did as a total bucket, as did physicians, as did nurses. But the standard deviations were very big, I might say. 100,000 virtual patients, we talked about that. Here's the meat of our research. You are, as an opioid use disorder patient, twice as likely to encounter somebody who holds you in significantly low regard, a proxy for bias, as somebody who holds you in significantly high regard, a proxy for compassion. And that's significant. So when we talk about conclusions, the model clearly demonstrates bias against opioid use disorder patients, which may not be most surprising, but it does confirm it. But maybe more interestingly is that the bias is uniform. It's not one particular area that's biased against these patients. There are compassionate staff members, but unfortunately, opioid use disorder patients are going to see uncompassionate people twice as many times as they are going to see compassionate individuals. And so what can we do to improve? Well, I think it goes back to education and training. And since it is a pervasive issue, it means educating everybody and training everybody on this. However, when we look at the flow diagram, we do see that patients spend more time with nurses and ED techs than they do with anybody else. So perhaps that would be a particularly lucrative return on investment to start there. So this is my work. I am passionate about it. Please feel free to give me questions or comments. I really appreciate the opportunity to be here.
Hi, my name is Tori Wiley, and I have the honor to present my project, Racial Disparities in Associations of Stress with Risk of Coronary Heart Disease, a survey study. I would like to thank my team and my mentor, Dr. Moreno. We are affiliated with University Medical Center in New Orleans. I have nothing to disclose. Now, you may wonder, why is this important? Well, coronary heart disease is reported as one of the most common types of cardiovascular disease. And cardiovascular disease is reported as the leading cause of death globally. Stress, over time, can harmfully impact the cardiovascular system and has been associated with increased risk to developing coronary heart disease. Psychosocial stress, perceived stress, and social factors play a role in predisposing individuals to the development of coronary heart disease. Those studies have assessed work-related or occupational stress. Empirical data linking stress and increased coronary heart disease risk among patients, ancillary staff, medical students, nurses, and physicians within the emergency department is limited. Therefore, our study aims to identify the association between stress and increased coronary heart disease risk. We like to determine if other modifiers of stress are related to increased risk of developing coronary heart disease reported in the emergency department during emergency care, and also assess the effect of race, age, gender, and discrimination as a moderator on stress affecting the risk of coronary heart disease. The methods of our study included creating a 70 to 85 question survey using validated tools. We created the survey using REDCap, and we stored the data using REDCap. In collecting the data, we obtained informed consent from each participant, and the survey was taken in the emergency department of University Medical Center, New Orleans, online and on pen and paper. We analyzed the data using SAEM21, Fisher's exact test, and linear and logistic regression. And looking at the characteristics of our population, most were patients, female, white, between the ages of 25 to 34, and non-Hispanic or Latino. We looked at the coronary heart disease and discrimination results. Among those who had high CHD scores, 24% felt they were being discriminated against with regards to gender, compared to the 76% who felt they were not being discriminated against. Among those who had low coronary heart disease scores, 46% felt they were being discriminated against with regards to gender, compared to the 54% who felt they were not being discriminated against. There was a p-value of 0.0475 with regards to gender. We also explored the perceived stress score results. There were outcomes of moderate and low perceived stress scores. Findings show that males, age groups 35 to 44, Asian individuals, and nurses had the highest average of mean scores. And looking at the other moderators, perceived stress score had a p-value of 0.1570. Age had a p-value of 0.0031, and race had a p-value of 0.0214. Overall, the findings show that perceived stress is not a risk factor for developing coronary heart disease reported by patients, ancillary staff, nurses, students, and physicians in an emergency setting, with the p-value of 0.1570. 52.1% reported high scores for a risk of coronary heart disease, and 24% of those responses reported discrimination as a risk factor with regards to gender, with that p-value of 0.0475. Logistic regression showed perceived stress scores and discrimination were not statistically significant. However, linear regression with an interaction term showed age to be statistically significant with the p-value of 0.0031 and being Black as a risk factor to developing coronary heart disease with a p-value of 0.0214. The statistically insignificant results may be due to the small sample size. Self-perception of stress during COVID-19 could have also played a role in participants' responses. Since this is an interim analysis, further exploration is necessary to determine if the validated tools fully reflect overall stress. In addition, we will need to assess what role resilience plays in one's self-reported level of perceived stress. Thank you.
Hello, my name is Cynthia Ramirez. I'm a doctoral student at the Keck School of Medicine of the University of Southern California. Today, I'll be sharing results from a qualitative analysis of influences of emergency department care-seeking behaviors. I'd like to begin by sharing that I have no disclosures and/or conflicts of interest related to this study. The objective of our study is to better understand the care-seeking behaviors of patients at a safety net emergency department, particularly in documented and undocumented patients. Our research questions include: how do patients decide when to seek emergency care services, and how do patients decide where to seek emergency care services? Our eligibility criteria for screening potential participants are as follows. Patients must be pending admission. Patient's reason for visit must include abdominal pain, distension, and/or discomfort, and/or nausea, vomiting. Patients must have an ESI score that's greater than or equal to 3, and patients must speak English and/or Spanish. We chose to conduct purposeful sampling to ensure that study participants have sufficiently complicated medical problems to require emergency department care, but are not critically ill to the point where they cannot participate. All adult patients who meet the above criteria are approached and invited to join the study. Successfully enrolled participants are then interviewed on their care-seeking behaviors and experiences using semi-structured audio-recorded interviews. We use a grounded theory approach for our analytic strategy, all of which was conducted by 2 separate coders. Our analytic strategy includes transcription and translation, line-by-line coding, axial coding, and extensive and detailed memoing. Memos are used to guide coders through the constant comparative iterative process. Coders conducted 4 rounds of independent coding with comparison for the development of the current codebook. As of March 2020, a total of 14 interviews have been conducted. 9 of our participants identify as Hispanic Latino, and 6 identify as undocumented. Participant ages range from 27 to 71 years old, and interview lengths range from 13 to 42 minutes. Our current codebook is composed of 13 axial themes and 7 sub-themes, which you can see here in the chart, with an excellent pooled kappa agreement score of 0.94. Results indicate that patients' ED care-seeking behaviors are influenced by their perceptions of symptom severity and manageability, systemic barriers to care, and previous healthcare seeking experiences, particularly as they relate to xenophobia and stigma. Additionally, though these will not be discussed in detail during our presentation today, themes of patient-provider communication and healthcare agency emerged. Patients' perceptions of symptom severity and manageability influence their care-seeking behaviors. Patients perceive blood loss, the worsening of symptoms over time, vomiting and/or diarrhea, feelings of extreme exhaustion or fatigue to the point where they can no longer engage in their usual day-to-day activities, and feelings of difficulty breathing as prompts to seek emergency care. Additionally, patients describing influence to seek emergency care services if others, such as friends or family, bring their symptoms and/or their seemingly declining health status to their attention. Patients also determine that emergency care seeking is warranted when they anticipate systemic barriers to care. Patients perceive their lack of insurance and documentation status as systemic barriers to care. Other barriers to care discussed by patients include competing priorities, such as deciding between the loss of multiple days' income due to missed work or seeking emergency care services, and lack of transportation. Finally, patients' previous healthcare seeking experiences influence their emergency care seeking behaviors. Patients refer to their previous positive and/or negative care experiences when seeking emergency care services. For example, patients describe choosing to seek emergency care services after an unresolved visit or visits to preventive care clinics, or following a negative interaction or interactions with providers at other care facilities. Additionally, patients' previous experiences of xenophobia and/or stigma influence their emergency care seeking behaviors. Patients reflect on incidences of negligence, direct discrimination, and/or perceived discrimination or stigma when choosing when and where to seek emergency care services. Furthermore, additional themes related to patient-provider communication and healthcare agency emerged in the data. Specifically, Spanish-speaking and/or undocumented patients describe their provider's ability to speak Spanish as important for how they master and/or relinquish their healthcare agency. Additionally, the ability to interact with bilingual providers appears to influence Spanish-speaking patients' overall perception of patient-provider communication. In conclusion, patients determine emergency department care seeking is warranted when symptoms are severe enough, when they anticipate systemic barriers to care, and prior experiences at hospitals or clinic-based care have been disparaging and/or inadequate. Undocumented and documented patients differ substantially in how they experience care seeking and systemic inequities in care seeking. Thank you very much for your time.
Hi, my name is Shilpa Kumar. I am a second-year medical student at the University of Washington School of Medicine, and I worked with Dr. Duber and Dr. Sabatini on a project titled Disparities in Cardiovascular Outcomes Among Patients with Mental Illness Following Emergency Department Discharge for Chest Pain. For our disclosures of commercial relationships, none of the authors have any financial conflicts of interest to disclose. And this work is supported by the grant shown on the screen. To start with some background and motivation for this project, patients with mental illness experience disparities both in the quality of care that they receive as well as their health outcomes, and this is often in relation to their cardiovascular health. However, few studies have examined whether patients with mental health conditions experience different cardiovascular or CV outcomes compared to those without mental illness in the emergency department or ED setting. The purpose of this study was to examine disparities in cardiovascular outcomes among Medicaid beneficiaries with and without mental illness following an ED visit for chest pain. We performed a retrospective review of Washington State Medicaid claims from 2010 to 2017, and we had over 100,000 visits accounting for patients with a diagnosis of nonspecific chest pain. For our patient population, we also had various exclusion criteria as listed on the screen. For our comparator groups, we looked at ED visits among patients with and without mental illness. We also examined a subgroup with serious and persistent mental illness, which included major mood and psychotic disorders with 2 or more claims in the past year. And both the presence of mental illness and the presence of serious mental illness were captured from claims data using the Washington State Department of Social and Health Services criteria for mental health service. Our outcomes included the incidence of a major adverse cardiac event, or MACE, within 30 days and 6 months of ED visit discharge. MACE was defined as a composite of death, myocardial infarction, or MI, CV rehospitalization, or revascularization. For our analysis, we first looked at unadjusted rates of outcomes and patient characteristics among patients with and without mental illness. We then performed multivariate logistic regressions to assess the associations between mental illness and the outcomes of interest. We adjusted for various covariates, including race, gender, age, Ehrlich-Hauser comorbidities, as well as baseline ED visits and inpatient hospitalization rates from the past year. These are some of the unadjusted rates of patient characteristics that we found. For our analysis, we only looked at ED visits ending with a treat and release disposition from the ED. So we had almost 100,000 treat and release ED visits with a diagnosis of nonspecific chest pain. 75% of these treat and release visits involved a patient with a documented mental health condition. 61% of visits involved female patients. And for our outcomes, we had a very low percentage of ED treat and release visits among patients with mental illness and without mental illness that ended in these outcomes. For example, only 0.46% of ED treat and release visits among patients with mental illness ended in a MACE 30 days after discharge. And similarly, all the other outcomes also had very low unadjusted rates. These are the results of our logistic regression models. Here, we're looking at adjusted rates per 1,000 ED visits of MACE within 30 days and MACE within 6 months, comparing mental illness to no mental illness. And we found no difference between mental illness and no mental illness looking at the rates of these outcomes. So for example, we found no difference of MACE within 30 days, looking at mental illness versus no mental illness, and the same was found for MACE within 6 months. Here are some further results of our logistic regression models looking at other cardiovascular outcomes that made up the composite of our MACE variable. And the only significant difference we found was for CV hospitalization within 6 months. So we did find that patients with mental illness had an increased rate of CV hospitalization within 6 months compared to no mental illness. The odds ratio was 1.87 and the p-value was 0.005. Not listed on the screen, we did see that the group with serious mental illness compared to no serious mental illness had higher rates of CV rehospitalization within 30 days of the ED discharge, but did not have any other significant differences in outcomes. In conclusion, mental illness was not associated with a significant different rate of MACE within 30 days or 6 months compared to no mental illness, but was associated with a higher rate of CV hospitalization within 6 months. The subgroup with serious mental illness had higher rates of CV hospitalization within 30 days of discharge from the ED. Something important to note is that because patients with mental illness have higher rates of rehospitalization within 6 months, this suggests that better care linkage and coordination is important for this patient group to prevent worsening illness. Some of the limitations for our study included a small number of outcomes and a higher proportion of visits with a documented mental illness. This made it difficult to elucidate trends in our dataset. Finally, further research should be conducted to investigate possible causes of the results shown on the screen. I want to thank Dr. Duber and Dr. Sabatini for their help with this project, and thank you so much for listening.
Hello, my name is Jessica Herrera Sartak, and today I'll be talking about our research regarding restraint use in the emergency department, specifically evaluating racial, ethnic, and language disparities. I have no conflicts of interest. So we know that patient factors like race, ethnicity, and primary language spoken can affect the patient experience and influence healthcare outcomes. However, there is very limited data regarding the effects of these factors on the rates of physical restraint use in the emergency department. We do have data from the psychiatric field in that being male or having a history of mental health disease or a history of substance use can predispose you to being restrained. But we have very limited data in terms of the risk factors associated with restraint use in the emergency department. So the goal of this study was to evaluate the role of race, ethnicity, and primary language spoken on the likelihood of physical restraint use among patients subjected to a Section 12A order. And a Section 12A order in Massachusetts is the vehicle that allows us to keep patients in the emergency department for a mandatory psychiatric evaluation in Massachusetts. In terms of our methodology, we evaluated all encounters in the emergency department between January 2018 and December 2019. We looked at 11 EDs across a large integrated health system in Massachusetts. All patient encounters with the Section 12A were included. And from that, we built 2 multivariable logistic regression models using a binary outcome variable, meaning looking at restraint use versus no restraint use. The first model included all main effects for all independent variables at the encounter level, whereas the second model was the same as model 1, but added additional interactions for race, ethnicity, and language at the different levels of biological sex, since we know that biological sex can be a predisposing risk factor for restraint use. Our independent variables of interest were, as we've mentioned, race, ethnicity, and language, and all of those are collected by registration. The patient self-identifies those. Additional independent variables included sex, age, insurance type, history of alcohol or substance use, history of mental health illness, as specifically defined as a history of bipolar disorder or a psychotic disorder, and history of homelessness, which is also collected by registration. So our results showed that we had 32,054 total encounters with the Section 12A, out of which 7.7% involved physical restraints. Out of those, most of them were in response to violent behavior. The demographics of our restrained patients showed that the median age was 36, but patients ranging from 6 years to 94 years old were restrained. 61% of our patients were male, which is an overrepresentation compared to our total emergency department population. African Americans are slightly overrepresented in this restraint pool. Hispanic patients are slightly underrepresented, and English-speaking patients are overrepresented. A logistic regression analysis revealed that certain factors were associated with an increased use of restraints, and those were male sex, this is biological sex, African American race, which is self-identified, as I mentioned, identifying as multiracial, having Medicaid insurance, and having a prior diagnosis of bipolar or psychotic disorder. There was also, on the second model, a significant interaction between primary language and sex on restraint use. Specifically, non-English speaking males were at a higher risk of restraint use compared to their English speaking male counterparts. And conversely, and interestingly enough, non-English speaking females were at a lower risk of restraint use compared to their English speaking female counterparts. And there were no significant associations between restraint use and any of the other independent variables. In terms of our limitations, we were unable to evaluate encounter level data because of the large sample size. It would have been prohibitive to look at the circumstances involving each use of restraints and whether there were additional de-escalation attempts that could have been attempted. And the other thing is that patient demographics and clinical information in the electronic medical record may be inaccurate or incomplete due to biases in the documentation process. Specifically thinking about the restrained population, if registration is trying to get information from an agitated patient, it may not always be possible. And therefore, there may be some biases in assuming somebody's sex, race, ethnicity, and primary language. But overall, the results of our study suggest that African American and multiracial patients under a Section 12A order are experiencing significantly higher rates of physical restraint use in the ED when comparing for other demographic factors, as well as a history of mental illness or substance use. And this underscores the importance of understanding and exploring the underlying factors that are contributing to these disparities, including the potential role of structural racism and provider bias. Thank you.
Welcome to the prevalence of lesbian, gay, bisexual, and transgender health education and training in emergency medicine residency programs. Where are we now? My name is Joel Mall on behalf of my colleagues from VCU, Emory, Mount Sinai, and LSU. We have no financial conflicts of interest. We have known identified inequities and disparities in lesbian, gay, bisexual, transgender, queer, and questioning health. However, there's been little or no education in medical school or residency for emergency physicians. With increased focus on health inequities and disparities, we wanted to re-examine the status of LGBTQ+ health education in U.S. emergency medicine residencies. Our primary objective was to determine how many EM residencies offer education on LGBTQ+ health. Our secondary objectives were to determine the number of actual versus preferred hours, identification of barriers, correlation of results with program demographics, and compare our current data with our 2013 study. We used the 2013 survey instrument. We emailed ACGME accredited EM programs who had at least one full class of residents in 2020. We sent reminder emails and posted reminders on the CORD listserv. These are the results. Table shown is our demographics respondents. Of 229 eligible programs, we heard from 113 of them for a 49.3% response rate. The majority, 75%, offered LGBTQ+ health education. The number of actual versus preferred hours did differ. We had an actual number of 2 hours of median delivered content with an interquartile range of 1 to 3, and preferred hours of 4 with an interquartile range from 3 to 5. Most programs had known LGBTQ+ faculty, 69%, and 81% had known residents. Having known faculty residents positively correlated with the likelihood of having content and how much content was delivered. Results by demographics did not show any significant differences between areas and regions or metropolitan size. It did show a slightly significant difference with private groups delivering less content with a median amount of 0 hours, and a preferred amount was also slightly less with 2 hours as compared to 4 hours for other types of employer type. The largest barrier cited was lack of time in the curriculum. We asked if programs delivered who had content on same-sex domestic partner benefits or known protections against LGBTQ+ discrimination or harassment. Interestingly, about a third of the program directors were not aware if they did. In the 7 years since our original 2013 study, in comparison, there was a significant increase in respondents' inclusion of LGBTQ+ content from 26% in 2013 to 75% in 2020. The median actual hours of healthcare education delivery went from 0 to 2. The median preferred hours went from 2 to 4. And the percent that had no time or felt that there should be no time to LGBTQ+ education was 16% in 2013, but it has decreased to 1% of respondents in our 2020 survey. The biggest barrier in 2013 was lack of perceived need. The biggest barrier in 2020 is lack of time. Known LGBTQ+ faculty went up slightly, and known LGBTQ+ residents went up from 56% in 2013 to 81% in 2020. We didn't have the granular data from 2013, so it's hard to know if these are statistically significant changes. Limitations: there are unique challenges to performing research on LGBTQ+ populations. Data was self-reported and thus subject to response bias. Individual interpretation of questions may also affect results. And although we got 49.3% of eligible programs to respond, non-respondents may have significantly affected our results. Finally, sexual orientation and gender identity are distinct and separate areas, and we did not seek to separate out what content was delivered in what area, nor did we intend to imply that they should be included always together. It's just the way they are commonly referred to, which is why we continued that in this study. Our conclusions: the majority of respondents offer education in sexual and gender minority health. There remains a gap between actual and preferred hours. There's a notable increase from 26% to 75% of responding programs providing education since 2013. Several barriers still exist, and the content, impact, and completeness of education remain areas for future study. Thank you so much for your time and attention. Feel free to email me with any questions. This is my program at VCU.
Hello, my name is Eden Engel Rebitzer, and I'm a medical student at the University of Pennsylvania. I'm going to be presenting a project entitled Patient Preference and Risk Assessment in Opioid Prescribing Disparities, a Secondary Analysis of a Randomized Controlled Trial. This was a PCORI-funded study and we have no commercial conflicts. And I'd like to thank the large team of patient investigators, study staff, and co-authors who contributed to this research. To start, as some background, Black patients are less likely than white patients to receive opioids for acute pain in the ED. While this disparity is a really robust finding, there are some important questions that are unanswered in the existing literature. First of all, it's unclear what role patient preference plays in these findings. While it's been proposed that patient preference differences may contribute to prescribing disparities through a shared decision-making mechanism, this is actually one of the first studies that directly examines the role of patient preference in opioid prescribing disparities for acute pain. Secondly, while there are a lot of theories, it's unclear what's driving these disparities or how to fix this problem. We address that second limitation by proposing and testing a new theoretical mechanism driving these disparities called inaccurate statistical discrimination. According to the theory of inaccurate statistical discrimination, disparities occur because decision makers, in this case clinicians, have incomplete information about their patients. In the absence of complete information, clinicians may apply false generalizations about a group to individual members of that group to fill in a knowledge gap. For example, a provider sees a Black patient in the ED who has some unknown risk of misusing opioids, and the provider applies the false belief that Black patients are at increased risk for opioid misuse to that individual patient and then declines to prescribe them opioids. In this study, we tested the hypothesis that inaccurate statistical discrimination is driving prescribing disparities by examining whether disparities were decreased when providers were given additional information about their patients' treatment preferences and opioid misuse risk. To do this, we used data collected for LifeStoried. LifeStoried is a large multi-center RCT that was conducted in the EDs of 4 academic medical centers. The trial recruited patients who'd presented to the ED with either musculoskeletal back pain or renal colic. And the outcome variables in this study were opioid prescription at discharge and preference treatment concordance. We defined preference treatment concordance as agreement between the patient's preferred pain management treatment and what they actually received at discharge. So as you can see here, if a patient didn't prefer opioids and did not receive them, or if a patient preferred opioids and did receive them, they were defined as concordant, and otherwise they were defined as receiving discordant treatment. Once enrolled, patients were exposed to both a patient and a provider-facing intervention. Only the impact of this provider-facing intervention was examined in the present study. So providers of patients who were randomized to the experimental arm received the 2 forms you see on the screen. On the left side of the screen, you see a form that was used to communicate patient opioid misuse risk to providers. It was based on the opioid risk tool, which is a validated metric for determining risk of opioid misuse. On the right, you see a form that was used to communicate the patient's preferred treatment for pain control to the provider. So in terms of our results, most patients, both overall and in all racial groups, did not prefer opioids, were not prescribed opioids, and got the treatment they wanted. That said, despite no differences in treatment preference by race, we found a marked difference by race in who actually got opioids. So 12% of Black patients versus 33% of white patients and 21% of all other patients were prescribed opioids at discharge. There were no differences by race in likelihood of getting your preferred treatment overall. That said, when we looked at preference treatment concordance more granularly, differences between racial groups emerged. Among Black patients, the largest discordant group was patients who preferred opioids but did not receive them at discharge, and 23% of Black patients were in this category. Only 6% of Black patients did not prefer opioids but received them anyway at discharge. Among white patients, on the other hand, the largest discordant group, about 18%, did not prefer opioids but received them anyway. Even after we accounted for other patient features, including demographics, presenting condition, pre-treatment pain level, and opioid misuse risk in a logistic regression model, Black patients had less than half the odds of white patients of receiving an opioid script. And this was true in the full study sample and when we examined separately patients that did prefer opioids and patients that did not prefer opioids. Here you can see the results of our intervention. We identified a significant interaction between race and presence in the experimental arm of our study. When providers were exposed to our intervention, and again, that was the study arm in which providers received additional information about their patients' pain management preference and opioid misuse risk, it actually appeared to exacerbate racial disparities in receipt of an opioid prescription. You can see here at a bivariate level, the control arm in blue and the experimental arm in red. In the experimental arm, you can see a bigger decrease in odds of receiving opioids when you move from the white group to the Black group. The same pattern emerged when this interaction was examined in our full multivariate model. So in conclusion, we found that Black patients in the ED were less likely than white patients to receive opioids for acute pain, despite no differences in pain treatment preference. When patients did not receive their preferred treatment, white patients received opioids more often than they preferred, and Black patients received opioids less often than they preferred. These disparities were not explained by differences in patient preference and were not eliminated by assessing and providing prescribers with patients' treatment preference and risk of opioid misuse. Future research should further examine alternate causal mechanisms underpinning these prescribing disparities and design interventions to reduce them. Thank you so much for attending this short oral presentation.